right, so let's look at chapter 25, which is bleeding. A lot of this information in the very beginning is going to be things that we have heard before as far as the components of blood. And then we're going to talk about the different types of bleeding, capillary, venous, and arterial. And then we'll talk about some treatments. I've also included a video of me performing these skills with direct pressure, pressure dressing, and tourniquet application as well. So it's very important that we recognize bleeding, that we understand how that bleeding is affecting the body, and that we understand bleeding can be external or internal, and kind of what our limitations are with each one of those as far as what we can do to control them. And remember that bleeding can cause weakness, shock, and even death. So really briefly, we're going to run through the anatomy and physiology of the cardiovascular system and look at the components of blood really quickly. So we know the cardiovascular system's job is to circulate blood to the cells and tissues, deliver oxygen and nutrients, and carry away that metabolic waste. And so we have our perfusion triangle, which are the three parts of the cardiovascular system. The heart, which is the pump, the container, which are the blood vessels, and then the fluid, which is the blood and body fluids. And any deviation or variation between these can lead to shock and ultimately death, as we've talked about previously. So the heart needs a rich and well-distributed blood supply for it to be functioning appropriately, and it works as its two paired pumps, the upper chambers, which are the atrium, and the lower chambers, which are the ventricles. And so then we have our blood vessels, which are all one inner working system. So we have our large arteries, which carry blood, oxygenated blood, away from the heart to distribute them out. So they become smaller arterioles that connect your arteries and capillaries. And then they become the capillaries, which are link the arterioles and the venules. And so this is where you start to have your oxygen exchange and your nutrient exchange in those capillary beds of the tissues and organs within the body. And then you have your venules, which empty back out into the veins, and they take those deoxygenated blood and waste products back to be filtered out and gotten rid of. So the oxygen and nutrients pass from the capillaries into the cells, and waste and carbon dioxide diffuse back onto the capillaries. So the blood itself contains our red blood cells, which we know that the red blood cells and the hemoglobin are kind of what's doing the job of carrying the oxygen and some of our nutrients there. We have our white blood cells, which are to prevent infection, platelets to aid with clotting, and plasma, which is the liquid portion of the blood. And so blood clot formation depends on several factors here. And so not only is it going to depend on the amount of red blood cells, the amount of platelets, it's also going to depend on where the injury is located at. If it's a injury to an artery that's under higher pressure, is going to bleed more. The clot's not going to form as easily until we overcome that pressure. If this is in a joint or an area that's been moved and bent, then you could have a lot of issues there as well with clot formation. So just really depends on a lot of things. The autonomic nervous system helps to monitor the body's needs and adjust the blood flow by causing that constriction and dilation of the blood vessels. And it automatically redirects blood to the heart, brain, lungs, and kidneys during an emergency. So it shunts that blood away from those peripheral sites and brings it to those vital organs when it senses that there is an emergency. And so this will help to keep our blood pressure at a decent rate, help to keep us maintaining homeostasis, and to help us compensate for a longer period of time. As we mentioned before, perfusion is the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. And so when that does not happen, we call that hypoperfusion or shock, right? And so we start to have cellular death. So it starts on a very small level, and if enough individual cells die, you have tissue death. If enough pieces of tissue die, then you have potentially organ death, which, let's say that's happening to one of your kidneys. You have two, so you could live, if they had to take one of those kidneys out, you would still be okay. But we were talking about heart damage, things like that. That's things that cannot be replaced, brain damage, and so that could quickly lead to death of the patient. Now, looking at external bleeding, the term hemorrhage can be interchanged with bleeding. So we talk about hemorrhage control. It is the same with bleeding. So with serious external bleeding, it may be difficult to estimate the amount of blood loss because it looks different on different surfaces. So you don't have to give, an exact amount, but you're going to be looking for a ballpark range of how much blood you estimate has been lost based off of what you see. And remember, blood can soak into clothing, blankets, towels. It can have a wicking effect, which can make it look more like more blood is there. It can make it actually draw more blood out of the wound, which we'll get to in a second. But blood's going to look a lot different in water. So if they've been bleeding into a toilet, it's going to look like more. If it's on a tile floor, it could spread and start to look like more. So just keeping in mind those different surfaces. The body will not tolerate a blood loss greater than 20% of its volume. And remember that compensation has a lot to do with how quickly the blood was lost. So if the body has time to make these changes, it has time to increase the heart rate, the respiratory rate, and to slowly kind of keep its eye on the blood pressure. Then we've got some time to work with that, and we can compensate for a longer period of time. If that blood loss happens very quickly, then it could be detrimental. So again, one example here, a patient could donate 1 unit or 500 mLs of blood over 15 to 20 minutes and be okay. But if that similar blood loss occurred because of a traumatic injury, then the patient would likely develop signs of hypovolemic shock. So you also have to consider their age, their pre-existing health conditions, other injuries, things like that, when you're kind of estimating how well are they compensating. So some characteristics of external bleeding. Arterial bleeding is the worst, and so this is going to be the most life-threatening. It's under a lot of pressure, which can cause the blood to spurt and make the bleeding very difficult to control. It's typically bright red because it's oxygenated, and it will spurt in time with the pulse. So any of those things, bright red, spurting bleeding, those should be red flags to you that this is arterial. Venous bleeding can be just as life-threatening, but it's a little bit darker. It does not spurt, and it can be easier to manage. Now, capillary bleeding is actually going to be the least life-threatening. So like a small cut here on the finger is what you see, and it's going to ooze kind of steadily, but not really going to be life-threatening. So these are the 3 examples they've provided here. Obviously, the fingertip, that is capillary. Up top on the right-hand side, that's venous bleeding, which as you see, that laceration is still pretty significant. But down here on the bottom, all right, if you don't know what you're looking at, because I didn't when this textbook was first published, I was not familiar with this, and it took some research to kind of figure out what was going on, because it looked like this was a nosebleed. And so even though you see a lot of blood there on the ground, you don't typically think about a nosebleed being life-threatening. But after doing some research, and if you're a sports fan, then you may have already known, this is actually one of the most severe hockey injuries, and it's going to be a carotid artery laceration. So I'm going to jump off of this screen for just a second, and we are going to pop on over and watch the video of this injury. Okay, so they're going to show it really quickly, and then they'll go back and look at it again. But just see if you can spot what's happening with the guy, and watch how quickly he begins to bleed and how much blood. So you didn't see what happened initially right here. But watch when they go back to the replay. The camera that they were showing was not originally on him, but they're going to go back and take a look. right, so as you can see with that, they actually went back and you don't see the size of the injury, but the amount of blood and how quickly it's coming out onto the ice, you could kind of tell just how severe that is, and that was coming from a skate that actually hit his neck right under his helmet. So that's going to be your arterial bleeding example for this chapter. So talking about clotting, the bleeding tends to stop rather quickly within about 10 minutes if it's not arterial, and especially if you're able to intervene here and allow for that clot to form. But you've got to overcome the pressure, and automatically the blood vessel is going to try to narrow to reduce the amount of bleeding. So the body is trying to stop it on its own as long as the patient does not have any type of clotting disorder like hemophilia. So remember, hemophilia patients, they lack that clotting factor, and so their bleeding can occur spontaneously or even very minor injuries that can become life-threatening. So they need to be transported immediately. Generally, these patients know that they have it. They may have been diagnosed at a very early age. They may take medications or receive treatments for this outside of what you're doing, and maybe your transport does not have any bearing on this, but just keeping it in mind. Now, looking at internal bleeding, this is bleeding in a cavity or a space inside of the body, and it can be very serious. It is not easy to detect immediately. The injury or damage to the internal organs commonly results in extensive internal bleeding, and it can cause hypovolemic shock. And the definitive treatment for this is going to be surgery in most cases. So these are just a few examples of times that you might see really severe internal bleeding. It could be a bleeding stomach ulcer, a lacerated liver, a ruptured spleen, broken bones, especially things like the ribs, femur, or pelvic fractures. So those are times when they're really going to need surgery. So looking at some mechanism of injury for internal bleeding, if it was high energy, this should increase your index of suspicion for more serious unseen injuries. Internal bleeding is possible whenever the mechanism of injury suggests that severe forces affected the body. So we're looking externally for any decap BTLS or other signs of the injury. Remember, if we're looking at the abdomen, we can look for that distension, swelling, things like that to kind of let us know. But rapid transport is really all that we can do. Sometimes bleeding is not caused by trauma, and so non-traumatic bleeding causes, if it's coming from, again, a sickness or an illness. It could be that bleeding ulcer that we just mentioned, bleeding from the colon, so any type of gastrointestinal bleeding, a ruptured ectopic pregnancy, which we mentioned during our GYN chapters, or aneurysms, which we've talked about before, how those can form. So if we're talking about GI bleeding, there are some questions that we want to ask along with this, as far as, have you had any vomit? Have you had any vomiting? Was there blood in the vomit? But also don't limit yourself to bright red blood, because remember that the closer to the surface it is, the brighter it will be. So when we're talking about GI bleeding, if you have some bright red blood in your vomit, that's usually coming from like the esophagus. If it's dark and like black or coffee ground material with a very unique smell, that's usually where it's coming from, the actual upper GI tract. And then lower GI we would be asking about bowel movements or feces. So if it's black, tarry, black blood that's watery, that type of thing, we're definitely asking about those types of things. So some signs and symptoms of that internal bleeding: pain, swelling in the area, distension, especially of the abdomen, dyspnea, difficulty breathing, tachycardia, hypotension, a hematoma to the area, bruising, bleeding from any body opening, hematemesis or vomiting of blood, melena or bleeding in the stool, pain, tenderness, bruising, guarding, swelling, broken ribs, bruising over the lower part of the chest, a very rigid, distended abdomen, or if the patient is going into shock for no explainable cause, then we can definitely want to start looking more closely at the possibility of internal bleeding. So we want to make sure, of course, that we are safe, that we're being alert to any potential hazards, and that we're following standard precautions here. Definitely want to have our gloves, eye protection, maybe a face mask, especially if we are talking about a lot of severe bleeding. Considering the need for spinal immobilization and additional resources, Don't be distracted from identifying life threats. So remember, a lot of times our external injuries can look very graphic, even if they're not that serious. Injuries to the face and to the scalp, those are very vascular areas, and they can look a lot worse than what they really are. So it looks like you're losing a lot of blood, or it just looks really bad, but that's not going to be necessarily a life threat. So don't let that deter you from continuing your assessment to making sure that the patient is having adequate breathing, that their circulation is still good. We're looking for skin temperature, color, condition, pulse rate, rhythm, and quality. And we want to control any external bleeding. And remember, this is happening during the primary assessment if it is a life threat. Okay, if it's not a life threat, if it's a small laceration to the arm with minimal bleeding, continue your assessment. But if we're talking about that bright red spurting bleeding, the need for a tourniquet, that needs to happen very quickly in the primary assessment before you continue on. Because if you've got, I'll just use the femur for an example. Let's say you have got someone who is bleeding from an injury to their femoral artery. If you do not address that and treat that before moving on, by the time you make it back around to your secondary assessment, likely the patient will have bled out. And so kind of the same thing when we're doing if we're managing a cardiac arrest and it's related to blood loss from trauma. Okay, so I use that same patient with the injury to the femoral artery, and this is a scenario I have used for TSOPs before. If they have got a life-threatening arterial bleed, if you start CPR before you address that bleed, then you're just pumping blood out of the dead body. You need to put the tourniquet on first and then come back and begin CPR. So keep those things in mind. Now, that's a very unique situation, but it's usually something that's asked in class, so I figured we would go ahead and address it here. So we want to determine our transport priority. Is this the same as with everything, load and go, or is it going to be stay and play? Do we see those signs that we need to be intervening and beginning to treat for shock? We want to ask questions about the chief complaint, get a sample history, asking, are they taking blood thinning medications? Are they taking anticoagulants? So things like, something that's going to help with clotting. So not just blood thinners, but are they taking medications like even a simple aspirin a day that could prevent clots from forming? If the patient is unresponsive, try to get their medical history from medical alert tags, cell phone, or bystanders, family members that may be there. When we're doing our secondary assessment, we want to look at vital signs here. Remember that a systolic blood pressure of less than 100 with a weak rapid pulse might suggest a presence of hypoperfusion. Now, generally, we start to think that we want to maintain a systolic blood pressure of over 90 in a trauma patient. So that just depends on what literature you're looking at, as whether they say 90 or 100 is going to be acceptable. Historically, 10 or 15 years ago, our big thing was to give as much fluid as we could to trauma patients. But what we know now is that actually by not diluting what blood they have and allowing it to just go at a lower pressure around 90 systolic, it can actually be more beneficial for the patient. So that's kind of our goal there, is just to maintain that blood pressure of over around 90 systolic. So just keeping that in mind as you are conducting your assessment. You're also now going to be looking during your secondary assessment for any DCAT, BTLS, any bleeding that was not a life threat can now be addressed at this point. We're, looking for PMS in all our extremities, looking for signs of internal bleeding. And then we're going to reassess, and again, every 5 minutes if the patient is potentially unstable, and every 15 minutes if the patient is stable, and we're going to be communicating with the hospital what's going on. So again, if we're transporting to a trauma center and we have identified that this patient is probably in need of some type of surgery very quickly, and we're doing rapid transport, we're going to give them a pre-alert. We're going to let them know, what exactly we're looking at, how much blood has potentially been lost, what have we done for the patient, and then what are we looking at right now and our estimated time of arrival. So we're going to communicate all of this information with the receiving hospital, and then also make sure that when you're documenting that you're putting in, everything that you did, all the same information. How much blood do you think was lost? Is your direct pressure working? Did you have to move forward to a tourniquet? That type of thing. So looking at some treatment for that external bleeding, like I said, I posted a video that is going to demonstrate all of this for you guys as well, but just take a look at this, making sure that you're wearing your standard precautions, so the proper PPE, making sure that you're maintaining the patient's ABCs, and then if it is a life-threatening bleeding, that we are addressing that as quickly as possible. So first and foremost is going to be direct even pressure. They've knocked elevation off, so that's actually not a relevant recommendation anymore. So it should be direct pressure, then pressure dressings and tourniquets. So tourniquets previously were a last resort. It's not so much anymore. So we're going to take a look at a few things here. So direct pressure is the most effective way to control external bleeding. The pressure stops the flow and permits normal coagulation to occur, and you want to apply pressure with your gloved hand or over the top of a sterile dressing, and hold uninterrupted pressure for at least 5 minutes. Now, after that 5 minutes, you have a couple of options. If this worked and the direct pressure held and stopped that bleeding, then yes, you can go ahead and put on a pressure dressing to maintain that. But if it's not working, and I would say even if it's within the first minute or two, not even waiting 5 minutes, if you notice this is not helping to stop that bleeding, then you want to go ahead and consider the need for a tourniquet early. Putting a tourniquet on does not necessarily mean that the patient is going to lose that limb. I know that that's kind of one of those myths that we've always talked about, but that's not always the case, especially if you act very quickly and the tourniquet is placed appropriately. So we want to make sure that we are putting a tourniquet on early if we need to. Now, if the direct pressure works, then we can move on to putting on that pressure dressing. And so again, in my video, you'll kind of see how you're going to stretch that bandage tight enough to control bleeding. You can rotate it a couple of times to create some type of pressure point there. And we can apply additional pressure over the dressing if we need to, and add more dressings over the first. Now, with that being said, when you've got gauze held to an openly bleeding wound, this is one of those things that has been changed every few years throughout the world of medicine, which is, should you add more gauze or should you not? Should you take it back down to the wound itself? And so there's a lot of things to consider there. If you take all the way down to the first layer and you remove everything, then you could potentially disrupt that clot. But if you keep adding more dressings onto the outside, you could cause that wicking effect, which could actually draw more blood out of the wound, which we don't want either. And so now kind of what the recommendation is that if you are going to if they're bleeding through continuously and you need to add more gauze, take it down to that first layer. Leave that first layer that's in contact with the skin or the wound itself in place if possible, so that we don't disrupt the clot formation, and then add more gauze on top. So we're not going to have a huge amount of gauze here, but we need to change them out if we need to, if they're continuing to bleed through. You also have the possibility of utilizing hemostatic agents. So remember, these could be the powders like Quick Clot, or it could be the Quick Clot where the powder is embedded into the gauze, which is most likely what you will see. And so I'm also going to post a video about wound packing. That's going to be most really relevant with the hemostatic agent. And so you'll kind of see how that works, where we want to get that really close down to the wound itself. And then, like I said, with the tourniquet, it really depends on what you're doing and what's going on as far as how quickly you do this. If you need it, you need it. Go ahead and slap that thing on. You can use a commercial tourniquet or create one yourself with a bandage and a stick or a rod. So again, you'll see both of those in my video. Now, this can only be applicable if the injury is on an extremity. Obviously, we cannot use a tourniquet if the injuries are on the trunk of the body or on the face and neck. So these are limited in what we can do as far as using them on extremities. Remember, we never want to place that tourniquet directly over a joint. We want to go about 2 inches above the site of the injury or 2 inches above the joint. Make sure that it's tightened securely. Never use anything that's thin that could cut the skin. And we want to never loosen it. So if the patient has already tried to make their own tourniquet, like with a belt, even though that's not something that we would ideally do, we want to leave that in place and put our tourniquet above it. And same thing if you have a tourniquet on and it's managing the bleeding, but it begins to bleed during transport, do not loosen or take that tourniquet off. It needs to stay in place. We want to make sure that we're putting another tourniquet on above that one, about 2 inches above it. So just some things to consider. Splinting, when we're using splinting to immobilize to help with bleeding, it's not really about the broken bones. It is to help prevent other soft tissue damage, but also to help limit the motion or movement. As I mentioned before, it can have a hard time clotting if that injury is at a joint area or that's, having a lot of movement. So you might need a splint to just immobilize to prevent additional bleeding. Bleeding from the nose, the ears, and the mouth, there are several things that could cause this. It could be skull fractures, facial injuries, could be sinusitis, infections, dried or cracked nasal mucosa, could be high blood pressure, coagulation disorders, or digital trauma like nose picking. So epistaxis or nosebleed is a fairly common emergency, and occasionally it can cause enough blood loss to send the patient into shock. We want to do a couple of things here to help with that nosebleed. First and foremost, we're going to pinch the nose at about the bridge of the nose and pinch those nostrils together. We're going to have the patient lean forward, not backwards. We don't want that blood to become an airway compromise by running down the back of the throat. And then we are going to potentially apply an ice pack or ice right over the bridge of the nose as well, while we're holding that pressure to help cause some vasoconstriction to the area. And as a last resort, if that does not work, you can use Afrin, which we talked about during pharmacology. Remember, we don't want to use it if the nosebleed is coming from the high blood pressure. So that would be our biggest contraindication there, would be if the patient has hypertension with their nosebleed. Okay. So we don't want to pack anything into the nose or to the ears. You could loosely cover the bleeding site with sterile gauze. We could do the halo test if we are concerned about potential for cerebrospinal fluid being there, but don't pack anything in there or hold too much pressure because we don't want it to cause additional injuries. And then lastly, looking at internal bleeding. So this usually does require surgery, as we said, or other hospital intervention. So the best that we can do is provide rapid transport and keep the patient calm, reassured, and as still and quiet as possible. That's going to limit the blood flow and the blood loss that is occurring if we can keep their heart rate and blood pressure down by keeping them laying down and as still and quiet as possible. So we can still treat for shock by having them in a supine position, maybe even Trendelenburg, depending on where the bleeding is happening. Provide high flow oxygen if they're having dyspnea, and then focusing on maintaining body temperature and then rapid transport. So again, please make sure that you watch the hemorrhage control videos. And again, there's going to be one of me performing the hemorrhage control skills, and then also I'm going to post one that is talking about wound packing. You need to watch both and be familiar with those processes for when we are back on campus. If you have any questions about this video, please let me know.